Dear students, today we'll be learning about the shoulder region. This is one of the first lecture in our MSK block. This lecture is content rich, and let's go for the objectives. Now, today we are expected to discuss bone, muscle, ligaments, and joints along with the neurovascular bundle. Then we are expected to identify soft tissue and the bony landmarks on radiographs. We are expected to differentiate between a normal and a fracture bones within the given x-rays. And we should be able to explain the actions of the muscles who are produced by the muscles who are located within the shoulder region. And then we should be able to describe the joints. What joints will be covered within this region? The joints are glenohumeral, which is famous with the name of shoulder joint, acromioclavicular joint, and the last is sternoclavicular joint. And in the end, we'll be looking at the functional losses of muscles which are occurring due to the damages of neurovascular bundle. When we use the term neurovascular bundle, that means we are talking about the injuries or some kind of problems occurring to the nerves and the arteries. Now, you're looking at a human chest, a male one. And now what are the structures who are located under this anterior chest wall? So we know there are a bunch of bones. And the bones which we will be talking today are the clavicle, the scapulae, and the upper part of the humerus, along with the group of muscles who are located anteriorly, posteriorly, and laterally. Now, how we study these bones, we'll be studying them bare bones, and you're expected, and it's highly recommended. During this block, you should be visiting the labs, and in the labs, spend your time in identifying the structures which has been explained during these sessions on the given models, given bones, and the cadavers. And now, how we can label these bones on this given X-ray. Let's learn it. Let's identify it. So there, this number one, what do you think this number one structure is? This is a bone which is called clavicle. Let's label it. Let's make it different. So now we can see that this clavicle has been given the borders with this yellow. Then what is this structure, which is number three? That is the coracoid process. It resembles the beak of a crow. And this number two is the acromion process. And then we are looking at the upper end or the proximal part of my humerus bone. And then we can see the head. This red line demarcates the head from the rest of the humerus. And then this 4 and 5, these are the tubercles, which we have discussed already, the greater and lesser tubercle. And in between, I don't know, you can see it or not, here is the location of intertubercular sulcus or the bicipital groove. Now, what is this number 7? This number 7, if you can see this underline, this is my glenoid cavity or glenoid fossa. And you can see there here, the head of my humerus and this glenoid cavity, they are in making a joint, and this joint is my glenohumeral or the shoulder joint. It's an example of a multi-axial, and we can see the similar structure in this location. Now, what we see here, guys, this is an X-ray, the same X-ray which we have seen, and now we know these structures. Now, can you find any abnormal features? Anything which is altered, any altered anatomical structure? How we can confirm that this humerus is well placed? Kindly focus here. Just see that there is a circle and there is another circle. How we do it? We can use this image. So you can see that these circles should be matching. That explains that this head of the humerus is well in contact with the glenoid cavity of my humerus. So this is a normal X-ray, and this is taking an anterior posterior view. Regarding the views, we'll be talking in more details when we'll be talking about more about the radiological images. Now, we are looking at different muscles. My upper limb is connected with my body with a group of muscles. They are located anteriorly, they are located posteriorly, and they are located laterally. So what are these muscles? And you can see few of them. You are looking at the pectoralis major, the deltoid, and the biceps, along with the bones who are contributing here. Now let's label this. This is an upper skeleton, and let's label all these structures. Now you're looking at the clavicle. This is my scapula. And this is the, what do you think this structure is? Acromial process. And then there's a joint between, laterally my clavicle meets with the acromion process. And this is acromioclavicular joint. And there you can see the coracoid process. Now this is the sternum, this gray structure. It has three parts. You're looking at the manubrium part of the sternum. This is the body, and these are the xiphoid processes. So these parts, they are well connected with each other. And then at the upper end of my manubrium, can you see there is a dip here? That is called jugular notch. And now there is another joint where my clavicle is articulating with the manubrium of the sternum. So this is sternoclavicular joint. So my clavicle is fixed. It lies horizontally and it's fixed at the middle end with the sternoclavicular joint, and at the lateral end at the acromioclavicular joint. This clavicle is the only bony attachment which connects my upper limb with the bony cage. And this sternoclavicular joint is the only articulation through which my upper limb is connected with my skeleton. And now this green structure, what is that? Is humerus. And then you can see there's a joint between the humerus, head of the humerus, and the glenoid fossa or glenoid cavity. We call it glenohumeral or the shoulder joint. And at the bottom, you're looking at ribs, and these are the costal cartilage. Now let's take one clavicle out. And now you're looking at clavicle from its upper surface and from its under surface. Superior view and an inferior view. Clavicle is a modified long bone. You can see its location. It lies horizontally in human body. It don't have a medullary cavity. This is the first long bone to ossify, and it ossifies in the form of a membrane. Now let's label it. Now this is, what is this part? This is the posterior aspect. And this is, if that is the posterior, so that will be the anterior. And now you can see that this rounded end, quadrangular end, and this part is going towards my sternum. This is rounded, and we call it sternal end of the clavicle. And this flat part, which is the acromial end of my clavicle. So clavicle on one end is flat and other end is cylindrical and quadrangular. This lies medially and that lies laterally. You're looking at a left clavicle. Then on the upper surface is smooth because you can feel your own clavicle. You don't feel any raised areas, but on the undersurface, you can find a lot of bony projections. And these bony projections are, you can see the facet through which my clavicle articulates with acromion process. That is at the lateral end. And there you can see there is an impression. This impression is for attachment of my costoclavicular ligament. And there is a raised area, conoid tubercle, and there you can see a line, trapezoid line. These areas are, these elevations are, these rough areas are for the attachment of the ligaments. At the two ends of my clavicle, it is fixed with my bones with very strong ligament. These ligaments are so strong that they don't allow in the time of any trauma to the clavicle to dislocate either of the end. It's very rare, but it rather fractures. For our learning, the clavicle is further divided into the medial 2/3 part and a lateral 1/3 part. So the place where this 2/3 and 1/3 meet, that is the weakest point. And most commonly, if a clavicle fracture, it fractures in this location. That is a place where medial 2/3 and lateral 1/3, they join, they fuse. It doesn't mean that clavicle cannot fracture at other side. It can fracture at any of the location, but most commonly seen is this location. I hope we are fine so far. Now, we are looking at another clavicle within this X-ray, just showing you a normal clavicle and how it's been placed. Don't think this is detached. Guys, remember, there are some ligaments. Obviously, the X-ray has, the plain X-ray has its limitation. It cannot show you the soft tissues. It can only show you the bones, mostly. Now, what's wrong with this guy? He slips, and look at it, the pattern. When he's falling down, he's falling on his outstretched hand. We call it fosh, F-O-S-H. And fall on our outstretched hand result in so many problems. It's variable from adult to a child. We can have fracture. If I start from the hand, scaphoid. Then we can fracture distal radius, the possibility of fracture of distal humerus, and then lastly, the clavicle. So though there are so many locations which may result, which are connected to this force. So in this age, most likely fracture will be scaphoid plus minus, but the distal radius, and that is famous with the name of Colles fracture. We'll be learning when we'll be talking about the arm and the wrist. Now, what you see here, what you can see here, you can see here a fractured clavicle. Are we good with that? Let's color it. So you can see that the fracture fragments, they are not well aligned, and the bone is being shown with two different colors, and they are displaced. Once they are displaced, they move in different direction. Now look at it. You're looking at another broken or the fractured clavicle. What's here? Look at, this is the medial part and that's the lateral part. The medial part is going slightly up. There is a reason for this upward placement of this clavicle. And this end, as we have talked about, it is well anchored with these ligaments. So now look into this specimen, and there you are looking at the fracture site, and where you can see the medial 2/3 and the lateral 1/3. They are well nicely shown to you. Going further, now this is the mechanism. So now this image will make it very clear. Medially to the upper part of my clavicle at this location, we have attachment of a very strong muscle, which is called sternocleidomastoid. And as this clavicle is now free because it's broken, so this muscle tends to lift this broken segment up. That's why you can see it's going upwards. And the lateral end, it stays where it is. Reason, at the bottom, it is well anchored with two of my ligaments, which we have talked about. And these ligaments were the trapezoid and the conite. And they are well anchored. Now, after this, what can happen? If it's that much displaced, then we have to opt this option where we can see we can go for a surgery. So now you can see surgically, this is how we can fix a plate, and that's the lateral, that's the outcome. So you can see that the place and the plate and the screws, they are well in place. I hope we are fine. So this is one way of fixing a broken clavicle, but that's not the only way. We have so many ways, but as if this is not the class where we should go in these details, a simple sling can do this job, but it depends, and there are various indications for what are the cases who can be subjected for surgery and what are the cases who can be subjected for simple coffin collar type of slings. It's variable and it's beyond your level. So don't stress out for these things. Now, let's look at another bone here, and this bone is present where? What are the locations? So you can see from these images, it's present at your upper back of the chest. You have two of these. These are the scapulae, and this is its anterior view, and that's its posterior view. If you look at this bone very carefully, it's like a triangle. And this triangle, you can see it has borders, and it has certain angles, and it has certain processes. So let's label it. I'm labeling it fast. Acromion, we all know, coracoid process, glenoid fossa or glenoid cavity, any term you can use. Now above to this glenoid, there is a raised area. We call it supra. Supra means above, supraglenoid tubercle. So if it is supraglenoid tubercle, there will be finding an infraglenoid tubercle. So then you are looking at the infraglenoid tubercle, both on the anterior view as well as on the posterior view. Then we can see these are the lateral borders. And then these are the inner ones are the medial borders. And now we are looking at the superior border. You can see that. And you can see now angles are coming up. This is the inferior angle. Guys, this scapula extends from my second to seventh rib normally. It can be variable. Inferior angle is quite palpable. And then along my superior border, there's a dip here. We call it suprascapular notch. And then on the dorsum, on the posterior view of my scapula, there's a raised area. We call it spine of the scapula. And there you can see that this area is named as the neck of the scapula. Now look at this. Because of the spine, the posterior surface of my scapula is being divided. This dipped area, this fossa, this number 1, we call it supraspinous fossa. And then this number 2, this area here, we call it infraspinous fossa. And then this number 3 here at this location, we call it subscapular fossa. Are we good so far? Any question? Now we can see that this was the inferior angle and this is my superior angle. Now this is another view of the same scapulae. We can see from the laterally, and this is where what we are saying, we are looking at from the top. And I'm sure everybody understands. And you can see very clearly the infraglenoid tubercle, and this is where the supraglenoid tubercle is. Now what I'm trying to do, I'm highlighting this glenoid fossa, and this black thing, which has just been shown up, that is the location where we have the attachment of the glenoid labrum. Now let's look at so now we are looking at the upper end of the humerus or the proximal part of the humerus. Now we can very easily identify the greater tubercle. Why is greater? Because it's great. And then you can see the lesser tubercle on both the sides, and you can see very clearly in between the intertubercular sulcus or the bicipital groove. Are we good so far? Now this red line indicates a very important landmark, and we call it surgical neck. Why is this important? The surgical neck is the most commonly fractured site within the proximal part of my humerus bone, and its location is corresponding to two very important structures, and these structures are the axillary nerve and posterior circumflex humeral artery. Think, if a fracture, if a force is that strong which fractures a bone, then how about these soft tissues, a nerve or an artery? So when you see any patient who walks to you with a pain, and when you do an X-ray, and if you see a fracture at this site, always suspect, unless proven otherwise, that look for the integrity of the nerve and look for the vascular things. So these are really important, and that makes you distinct, that you are acting like a pro. Are we good so far? So now you can see this black line which is going, and that is near the head. So this black line is the anatomical neck. So my humerus has two necks. One is the surgical neck and the other one is the anatomical neck. Are we good? Now let's look at from the top, and you can see that this is my same anatomical neck, and there we can see there are certain areas which are demarcated for muscles. So this is the place where my infraspinatus muscle is attached. This area belongs to my supraspinatus, and this one is going for my subscapularis muscle. You can see this gap. Through this gap, I have the passage of the long head of the biceps brachii tendon. Now, my upper limb is connected with my body wall, posteriorly with a group of muscles, anteriorly with a group of muscles, and laterally with a group of muscles. And these muscles, they are arranged in layers, superficial and deep. And remember, these muscles are present on both the sides. So don't be confused with the things. So we divide these muscles into extrinsics and intrinsics. What do I mean by saying extrinsic, and what do I mean by saying intrinsic? Extrinsic, outside. For your understanding, extrinsic, kharji, intrinsic, dakhli. So let's put, so I'll be using, so extrinsic muscle, what is peculiar about that? They attach the upper limb to the vertebral column, but intrinsic have some other job to do. Let's see that. So on this side, I'll be putting the deeper muscles, and on this side, I'll be putting the superficial muscles. So now the first muscle which is coming up, we call it trapezius muscle. And can you see here at the base of the skull, there's a prominent area. We call it external occipital protuberance. You can feel in your own body. And then can you see this whitish structure which is going downwards? That is a ligament and it has a name. We call it ligamentum nuchae. Now look at this muscle. I'm showing you half of it. The other half is present on this direction. So this triangle and a triangle, if I bring it here, that makes a diamond. And this is my trapezius. Now you can see that this is coming from external occipital protuberance, ligamentum nuchae. Then it's coming from the spinous processes of my thoracic vertebrae. And then all the fibers, they converge and they go where? They go to the spine of the scapula and the clavicle. Are we good so far? Then what it does, what is the main job of trapezius? It moves the scapula. How? That we have to see right now. So this is the first part. So these are the superior fibers. And what is their job? They elevate and laterally rotate the scapula. Middle fibers, what they're doing? They are bringing, if this part will contract, they will be retracting. You know, retracting, taking away, they will be retracting. So this middle fibers, they retract the scapula. And then this number 3. Obviously, we have seen superior, middle, now it has to be inferior fibers. And they do reverse. This superior was elevating, so it depresses. It was doing lateral rotation, so they will be do medial rotation. Guys, anatomy is not memorization only. It is learning with a concept. If you learn with the concept, your memorization part will be minimal. And if you try to memorize it, yes, you do, but you forget it so fast. So have a deep impact in your learning. Now, very important. A nerve who controls this muscle, if this nerve is not there, it's like a power supply. So who's that nerve who controls this muscle called trapezius? This nerve is my spinal accessory nerve. Simply remember the 11th cranial nerve, if you forget any other name. This nerve, if this nerve is not working, this muscle is not working. And now, guys, anything which comes blue in my slides, that is the action of muscles. For MSK, anything with red, this is not red. Anything with red is the clinical correlations, clinically significant points. So now what happens here? With other scapular muscles, we have others. What trapezius does? It steadies the scapula, so it stabilizes the scapula. When we are moving our arm and when we are manipulating the shape and the posture of shoulder. And upper fibers, what they do, they support the shoulder when we are carrying heavy weights. And we'll be learning these concepts in more details. Now, shrugging of the shoulder. I'm raising my thing. This is the shrugging. So if I ask a patient, shrug your shoulder, I have tested 11th cranial nerve. And with the trapezius, it's a very common cause of neck pain and stiffness. So that's why you can see people do massage on their trapezius. That relieves a lot. Now, this was a superficial muscle. Now we are coming to the deep muscle. The name says levator scapulae, someone who elevates my scapula. So there you go. You can see along the medial border, we have a tiny muscle which is going towards my cervical vertebrae. Which cervical vertebrae? First cervical to the fourth cervical vertebrae. To which part of them? To their transverse processes. And then what this muscle do? This muscle elevates the scapula and it is an assistant to the others. Are we good? Then Which nerves control this muscle? Dorsal scapular nerve. Guys, you will see these so many, these C3, C4, C5 and vice versa. You will be learning. Don't stress out today. Right now, just learn it that dorsal scapular nerve, which is a nerve from my brachial plexus, that controls my levator scapulae. I have highlighted here C5. We'll be talking in more detail about that. So once who's highlighted, it means this is the main contributor for this nerve. And this nerve controls my muscle. Are we good? Now, look at a complete trapezius muscle. Isn't like a diamond? So you can see the fibers, one half and the other half. You can see the upper fibers, the middle fibers, and the inferior fibers. And you can see its whole extent. And you can see the right and left muscle, they meet in the midline. And you can see its attachment over to the spine of the scapula on both the sides. And then it's towards the acromion and then going forward to the clavicle. And look at the schematic, the upper fiber, the middle fiber, and the lower fiber. And you can see from where they are coming and they are just attached on the area which we have mentioned. Now, we were here. Now let's put more muscles here. But before that, don't forget, there's another diamond. And this is not a muscle. This is a fascia. Fascia is a very thick, fibrous connective tissue, very strong. And what it does, it provides a base of an attachment. We call it, it's coming from my thoracic and lumbar vertebrae, so we call it thoracolumbar fascia. And from this fascia, we have emergence of this muscle, and that muscle is my latissimus dorsi. Guys, this muscle becomes very prominent in those people who are involved in rowing or swimming. This muscle becomes very prominent. And you might have seen people showing a V appearance in their back, and that is because of this muscle, latissimus dorsi. And this muscle is unique. You can see it's connected to the lower limb bones and it's going to the upper limb. You can see this is my ilium, a part of my hip bone. It's connected here, and there you can see it goes to the humerus along with going to the scapulae. So this is the muscle who's connected to the bones of the upper limb as well as the bones of the lower limb, both. Now this is the attachment to the hip bone, and that's the attachment to the humerus. Which part of the humerus does it go? You remember bicipital groove? So it goes and fills the floor of my bicipital groove. And then this muscle, this very strong muscle, who's controlling it? Thoracodorsal nerve. Ignore these at the moment. And what it does, this muscle, if it works, it's a powerful medial rotator. I hope everybody knows what is medial rotation. Guys, when we talk about an action, this action should be connected to a joint. So medial rotation where? At my shoulder, at some other place. So medial rotation, very easy to remember. When you're doing an arm wrestling, if you are winning, this is medial rotation. And when you're losing, your hand is open outwards, that is the lateral rotation. Where? At your glenohumeral joint. So it's a very powerful medial rotator. Adductor, you can see that when I pull, when this muscle contracts, it brings my arm towards the body. And extensor of the arm at the shoulder, that's important. So anything which is highlighted, which has underlined, you should be knowing this much. The other part is okay, good to know, but you must be good with that. So this muscle helps out a lot with so many front crawls, swimming, active in climbing and rowing, as I mentioned already. But what you should not forget, powerful medial rotator, adductor and extensor of the arm. Where? At the shoulder. So you have to be very specific. We always ask, be specific. What is the meaning of be specific? This is what is be specific. Are we good? Now, I have marked a green triangle here. What is that? Anybody would like to help me with this? Yes, very good. So this is my triangle of auscultation. When I have to hear the structures who are presenting in my thoracic cavity, I should be looking in space which is not covered by any specific muscle. There are muscles, but they are few in number. So this is an area which gives me the freedom. I can listen to a chest wall from the back, and this is called triangle of auscultation, and your physician put his stethoscope on this area to listen to the activities which is happening within when you're breathing in and out. So now we have learned about this latissimus dorsi muscle. Let's proceed. Now we are looking at, this was the superficial side. On the superficial side, we have learned what? The trapezius and latissimus dorsi and the angle of auscultation. Now on the deeper side, we have learned already about the levator scapulae. Now we'll be learning more deeper muscles. Guys, these all muscles are extrinsic muscles. And what are they doing? We learned in the beginning, they were connecting my upper limb with the vertebral column. So you're looking at a muscle which is about to come, rhomboids minor muscle. The rhomboid, you remember that your geometry classes, you're learning a shape like square, rectangular. Rhomboid was another shape which was explained there. So rhomboids minor, you can see that it is also coming from the medial border of scapula and it's going to the corresponding vertebral spines. So what are those? And then you can see the another muscle, that is my rhomboids major. Minor is tiny, major is big. And both of them, they are coming from the medial border of scapula, and then they are going where? Spinous processes of 7th cervical to T1, T2, T3, T4, and T5 spinous processes of these thoracic vertebrae from C7 to T5. And the nerve who controls these two muscles is the dorsal scapular nerve. And both these rhomboids, they retract medially. What they do, they retract the scapula medially, and they are used when bracing or squaring the shoulder. So when you're doing that, so at that time you're using it. Now look at it, a complete latissimus dorsi, thoracolumbar fascia. And you can see it's going to the floor of my bicipital groove. Its schematic attachment, you can see its attachment to the iliac crest, all these lumbar and thoracic vertebrae, and then to the inferior angle of my scapulae, and all of them, they converge to one point at the floor of my bicipital groove. And then you're looking at the levator scapulae, rhomboids minor and rhomboids major. Now, we have talked about those muscles who connect my upper limb with the vertebral column, but we have only talked about the extrinsic layer. We have not talked about the intrinsic layer. But right now I have moved to this anterior chest wall, and there I like to go over this anterior extrinsic muscles. So those muscles who connect my upper limb with my anterior chest wall. And I will start from the deep and I will come to the superficial part. But first of all, I will talk about a muscle who's located laterally. This muscle is really important. And on this side, you're looking deep, and on this side, you're looking superficial. So now the deepermost is the serratus anterior. The word serratus means serrations. So it has so many digitation. The serratus is from the comb. So it comes like so many serrations, and they are coming up. And you can see that so many serrations, and they join, and this muscle arises from these ribs, outer surfaces, and all of them, they converge to one common, and then it's going to be attached on the inner aspect of the medial border of the scapula. Medial border of the scapula, we have seen, we have used it for rhomboids. That was from the outer aspect. And the inner aspect, we have this serratus anterior. Guys, we have so many serratus muscles, but right now we are focused with the serratus anterior. So now what you can see, it arises from upper 8 or 10 ribs. So this is a figure. You may find in different books, different numbers. So don't be confused with that. Everything is fine. And then is attached to the anterior aspect, medial border of the scapulae. And this is very important. Long thoracic nerve, a very important nerve who controls this muscle. And if this nerve is damaged or there's a problem with this muscle, we encounter a very common clinical situation. What's that? We'll be looking shortly. So what are the actions made by this muscle? Guys, this is very important. This muscle gives an extra range to my hand to go further. So if I'm doing a boxing, I can have an outreach. So it moves, it glides my scapula So my hand has a more extension. My height is low and I have to approach to an maybe there's a bell, or I have to go for something. I have to fix a bulb. So then it gives an extra approach. So it increases the approach of my hand. So serratus anterior together with another muscle, pectoralis minor, it glides the scapula. It it brings the scapula forward. On what? On my chest wall. So it is bringing what? Protrusion of my scapula. And it is the prime mover. Guys, prime mover, you remember we talk about the functional classification, the agonist in all reaching. So when we are trying to reach to something, so that's where it's been instrumental, how it is protruding my scapulae and pushing movement of the arm. Are we good with that? So that we must be knowing. And we also call it boxer muscle because it gives an extra length to my hand so I can reach to the face of my opponent. Are we good? Now, there is my pectoralis minor, a tiny one. It is an assistant to this one. And you can see that it's coming from my third, fourth, and fifth rib. Guys, you may find in some books, second, third, and fourth. There is no rocket science, no problem. Swallow that. And this is my pectoralis minor muscle arising from third to fifth rib. Sometime even it's written here, second to fourth rib. So both of them, and where it's going, its destiny is going towards my coracoid process. Are we good? And who controls it? Lateral and medial pectoral nerve. You may find some of your books, they will only write of one of them. Oh, it's okay. I'm using gray here. So gray says, and I have seen, if you have doubt, I'll show you in the labs. That's not a rocket science. Pectoralis minor muscle, as we have said already, it assists the serratus anterior in protecting the scapulae. That is fine. Now, what is this red line? Red box. It's talking about long thoracic nerve, winging of scapula. What's that? As you know, this muscle is attached to the inner aspect of my scapula. So it steadies, it keeps the scapula adherent with my chest wall. So when this nerve is damaged, when it can be damaged, if it's a female, she had a breast cancer, and during the removal of his breast, that is called mastectomy. At that time, this nerve can be endangered, can be damaged. So if this nerve is not working, this muscle is not working. It loses its job. So let's see how and what happens. Now look at it. This is pectoralis minor first. You're looking at its attachments. Now this is my serratus anterior. Look at its serrations and going towards the medial border of my scapulae. You can see that very clearly. Now look at this. A person is standing in front of you and his shirt is being removed. Look at his scapulae. Is there any difference you find? This is little elevated, but it's okay. It's acceptable. But what happens? When this person, now he's at rest, but when he starts pushing against the wall, now this scapula goes weird. Look at it. This remains the way it was, but this becomes prominent. It means this scapula. The serratus anterior on this side, on the right side of this person, the nerve is damaged most likely. Serratus anterior is not working. So now there is no one who can keep this scapula adherent with the body, and now it is becoming obvious. So this is called winging of the scapula. Guys, when we talk about this term, winging of the scapula, the winging of scapula can be because of the two nerves. One is the long thoracic nerve. There are two terms used, medial and lateral winging of the scapula. The other one is connected to my accessory nerve. That I'll be talking in more detail when I'll be talking about the clinical anatomy session. There I'll be talking about that. So right now you can see that winging of scapula due to the loss of my long thoracic nerve. And only it becomes apparent when somebody tries to push against the wall. I know there are so many students even in our uni, more than 5, 6, they have this condition, they are behaving, doing, performing well, and they are scoring well. So it's not a painful condition, just relax. And if it's there, there are ways to take care of this. But it's as if it's not causing any major issue, someone can live with that. It's not a life-threatening issue. Now, this person, he's not pushing against the wall, but what he's doing, he's trying to abduct his arm. When he's abducting, when he's trying to do this action, now this starts becoming, look at it, compare from the normal to this abnormal. So this becomes evident now. So this is when I'm abducting. And look at it from this view, you are not very clear. But when I look at laterally, this becomes this wing become very prominent as if we start flying. Are we good? Now, so we have covered the deeper ones, and they were serratus anterior, pectoralis minor. Now let's talk about a superficial one. And there is my pectoralis major, a very major muscle. Look at it. Part of it is coming from the clavicle. That is the clavicular head. And then sternocostal head. And it has another head which comes from the abdomen. I'm not showing it here. So it has two heads, clavicular part and sternocostal part. And all of them, where they are going to my bicipital groove, not to the groove. There is a place there, lateral lip of my bicipital groove. That's its destiny. Are we good so far? Who controls it? Same nerve who controls my pectoralis minor. And that is lateral and medial pectoral nerves. And this is its action, guys. Very, very important. No issues. You should be very good with that. It's a major muscle, very obvious what it does. Flex, medially rotates, and adduct the arm. Where? At the shoulder joint. Internal rotation of the humerus is carried out mostly by the clavicular head. So clavicular head is primarily responsible for internal rotation. Muscle also swings the extended arm forward and medially. So when you are bench pressing, when you are in your gym and you are doing bench pressing, at that time this muscle comes in play. So you need to be good with that, and especially flexes, medially rotates and adducts the arm, and internally rotates where? At my shoulder joint. This is a must know type of information. I hope we are fine. Now let's look at the different views. You remember in general anatomy in the labs, you are told this muscle fiber, they converge and then they make a twist. Like your candy, they twist. Look at the fibers coming from the clavicle, sternocostal, and the abdominal fiber, and they make a twist. And this is the real one. Look at the clavicular fiber. You can see there's a demarcation very clearly. Guys, this is a picture from our own labs. You can come and see this cadaver. We have it. And this is, we have dissected this out during our dissection programs. You can see the deltoid very clearly, the clavicular part of the pectoralis major and the sternocostal part. And there, if you can keen enough, you can see the abdominal part is being showing us. And there you can see, this is my serratus anterior. Now I'm talking about, I have talked about what? The muscle who connects my upper limb with the anterior chest wall. Then I have talked about the muscle who connects my upper limb with the lateral chest wall. Then I have talked about the muscle who connects my upper limb with the posterior chest wall. So now we are done with the chest wall. Now we are talking about intrinsic muscles. So they are not connected to my vertebral column and they live in a close vicinity. Their journey is from scapula to humerus. That's it. They are internal. So this is an anterior view of my scapula and the humerus. This is a posterior view. So now this green thing is my capsule of my shoulder joint, glenohumeral joint. And then a very important muscle coming from supraspinous fossa and going to my tubercles of the humerus. And this is my number one, is my supraspinatus muscle, arising from where? From supraspinous fossa. And what it does, it's very important. It initiates the abduction. From 0 to 15, 0 to 20, 0 to 30, all is acceptable. But initiation of abduction is because of this. And you can see this muscle. This is going between the bones. Below is the bone, above is the bone. So this muscle is quite susceptible. If I have too much activity, there are fair enough chances that its tendon can undergo some degenerative changes or some kind of issues can occur. And we have a bursa here also. So it's the most commonly torn element of a rotator cuff. What is this rotator cuff? We'll be talking about it shortly. So supraspinatus tendinitis. When we use this word itis, that means inflammation. And then this brown thing is my infraspinatus. It's also going to the same location. And then what it does, infraspinatus, it laterally rotates the humerus. And this green thing is, what do you think is that? Teres minor. Are we good? It laterally rotates and weak the adductors of the humerus. And then from the anterior aspect, you're looking at this subscapularis muscle. So now this 1, 2, 3, and 4. If you can see this SITS and all these sits muscle, they are known as the rotator cuff. Are we good? So this one is the only one who goes to the lesser tubercle. And all these three, they are going to the greater tubercle of the humerus. Are we good? So the nerves who control these muscles, supraspinatus and infraspinatus, they have a common nerve, suprascapular nerve. Teres minor by axillary nerve. And subscapularis, upper and lower subscapular nerves. They are responsible for these muscles. And together, they are making this rotator cuff group of muscles. Now let's look at them. Supraspinatus, infraspinatus, and teres minor. You can see all of them separately. There you are looking at subscapularis. And then you can see all of them, they are coming to enclose this head of the humerus and looking at different location. So they are one of the stabilizing factor for the integrity of my shoulder joint. And look at it, this sits. There you can see supraspinatus, infraspinatus, teres minor, and this thumb is going for subscapularis. You can do this, you hold a humerus and you can do that. Now look at it, how they are connected and how they are stabilizing, keeping this humerus towards the glenoid cavity, glenoid fossa of the scapula. Now we were good so far, we talk about these, and now I'm introducing another muscle which is in a different color, and that is my teres major muscle. This teres major muscle, who controls it? Lower subscapular nerves. They are controlling this muscle. And then there we are looking at a muscle who covers all this, and that is the deltoid. It has been cut at the moment, and we'll be looking at it shortly. So now we'll be focusing around, there we have so many bursas. So to prevent this supraspinatus muscle, there is being provided a bursa, which is present under my acromion process, and this bursa is continuous. So that is preventing so many things, but still it's not enough. So part of this bursa, but the part which goes under this acromial process, we call it subacromial bursa, and the part of it which is located under my deltoid, we call it subdeltoid bursa. And then you're looking at another bursa, which is where my subscapularis muscle is attached. So now these bursas, they are susceptible to be inflamed, and because of this inflammation, we have these bursitis, and this will result in a painful arc syndrome. How we do it, I'll be showing in the next slide. So once they are inflamed, there are fair chances we give injection, anti-inflammatory injections, and some kind of remedies has been given to relieve. These are really painful conditions. Look at it. Look at the arm of this person. He's abducting, but it is really painful, and it is a very difficult task, and we call it painful arc syndrome. And you know the responsibility that goes primarily on this supraspinatus tendon. It could be tendinitis, it could be bursitis. So there are various possibilities which are occurring at this shoulder joint. Are we good so far? Now, we were here. Now let's bring in, so we talked about supraspinatus, infraspinatus, teres minor, teres major. So now we'll be talking about the deltoid muscle. But before that, we need to cover another important area here, and we call this quadrangular and triangular spaces. So what are these? You'll be covering today these things in the labs, and you need to be instrumental for these learning things. So these quadrangular and triangular spaces are really important. And let's see how we do it. Now I'm bringing a muscle. We have not talked about it yet. And this muscle is my long head of triceps. Now, because of this muscle, now can you see that? This is my humerus. This is my teres minor. This is my teres major. And this one is long head of my triceps. Can you see there is a space which is quadrangular? And this is a space which is like a triangle and a triangle. So I have one quadrangular space and two triangular spaces. Guys, you are expected to be good with the boundaries. Who's medially, who's laterally, who's inferiorly, who's superiorly. And same goes with these triangular spaces. And plus, what are their contents? So let's put, so from my quadrangular space, who lives here? We can see that there we have, it transmits my axillary nerve and posterior circumflex humeral artery and vein. And then this one, upper triangular space, what is coming out from here? We have the circumflex scapular artery, which is coming up from here. And from this lower one, very important structures are also coming from here. We have the radial nerve as well as the profunda brachii artery. So you are expected to be good. Who makes, what are the boundaries of these areas? So who are the structure, who are making the boundaries, and what are the contents who are coming from these areas? Now, let's talk about the deltoid muscle, a very important muscle who gives shape to my shoulder. And now you can see that this muscle is not one structure. We talk about it, it's multi-pennate muscle. And there you can see three different variants: the middle fibers, the posterior fibers, as well as the anterior fiber. And each group of fibers, as if they are distinct, they are different. So their performance should be different. And now look at it, all of them, they are just making this U-shaped structure, and they are attached over the spine, acromial process, and part of my clavicle. And this deltoid and all these fibers, they converge down to be attached on the humeral shaft at a location which is called deltoid tuberosity. Guys, these are those surface marking where we were emphasizing a lot. And now this muscle, who controls it? Axillary nerve. So primarily axillary nerve supplies my deltoid as well as my teres minor. Now these three sets, anterior fibers, what they do? Their action, guys, deltoid is again very important. Flex, adduct. Supraspinatus was the beginner initiation up till 50-20 degrees. Beyond that, up till 90 degree is the job of deltoid. So flex, adduct, and medially rotate. What? Shoulder joint. This is the job of my anterior fibers. The middle fibers, I'll be coming to that. Let's talk about the posterior fibers. They are reverse. They extend, but they adduct and laterally rotate, opposite to them. Are we good? And then we are coming to the middle fibers, and these middle fibers are the one who are responsible for abduction at my shoulder joint from 30 degree up till 90 degree. Beyond 90 degree, we have other stakeholders. Are we good so far? So now we are looking at the different views of my deltoid muscle from the front, from the back, and from the lateral view. And this is the schematic picture which is showing you the anterior, middle, and posterior fibers. Now, let's recap. Today we were learning about pectoralis major, deltoid. We talk about sternocleidomastoid a little bit. We talk about this trapezius. This is the biceps. You're looking at the serratus anterior. You're looking at, who's this? Latissimus dorsi. Front. We remove this pectoralis major. Now you can see pectoralis minor very clear and serratus anterior. And you can also see latissimus dorsi. There is another muscle which we'll be learning lately. Not today. Coracobrachialis. And the biceps, it's long head. Sorry, this is the long head and this is the short head. And then from the back, you're looking at the trapezius, deltoid, latissimus dorsi. You're looking at the triceps. And then you're looking at the triangle of auscultation. And then partially who's visible, guess Most likely it could be teres major. And then when we remove it, you can see more details. Levator scapulae, you can see this rhomboids minor, rhomboids major. You can see the supraspinatus, infraspinatus, teres minor, teres major, latissimus dorsi has been cut, deltoid, and triceps. Now we'll be talking about shoulder joint. When we talk about shoulder joint, it's not one. There are these 5 locations. But right now, we'll be discussing today about 3 locations, which are the bony articulation. One is this between the sternum and the clavicle, sternoclavicular joint. Clavicle and the acromion process, acromioclavicular. And the glenoid cavity and the humerus, glenohumeral joint. These 3 will be discussed today. So now, my glenohumeral joint is a ball and socket type of multi-axial joint. And its stabilizing factor is rotator cuff. Now, these are the bony landmarks. Let me go fast, just labels, that's it. We have talked about all these structures, nothing new here. Now, these are the bones who contribute in making my glenohumeral joint, the head of my humerus and the glenoid cavity. And look at it from the front and from the back. Now let's construct it. Before, we can just see these are few ligaments who are connecting my clavicle. We are looking at lateral part. So we are looking at the conoid and the trapezoid part of this ligament. And this is the acromial end of my clavicle. So these are the coracoclavicular ligament. Coracoclavicular ligament has 2 parts. One which is going to the conoid tubercle and one which is going to the trapezoid line. They are named accordingly, conoid and trapezoid. And then we are looking at the acromioclavicular joint, a joint which connects the acromion process with the lateral end of the clavicle. And then there is a ligament which is connected between the coracoid process and the acromion process. We call it coracoacromial ligament. And then there is another ligament which bridges this gap, suprascapular notch. Superior transverse scapular ligament. Guys, these ligaments are not concerned with my glenohumeral joint. Be very clear. Now, let's start making the glenohumeral joint. This green structure is the joint capsule. We all know about it's a fibrous structure which covers this joint. And then this capsule is reinforced internally by certain ligaments. And who are these ligaments? But before going to that, you can see the part of this capsule is soggy here. It's just, boggy is going downwards, and that is my axillary recess. Now, these are the reinforcing structures. Who's this? This is what is that? Coracohumeral ligament. These ligaments are present inside this capsule. I'm showing you outside just for your understanding, because all these ligaments, they are reinforcing, they are strengthening up this capsule. And then there is another one with a different color. So this is superior in location between glenoid and humerus. So superior glenohumeral ligament. And then this one, a grayish color. After superior, what comes? The middle glenohumeral, and this must be the inferior glenohumeral ligament. So all these 3, not this coracohumeral. These 3 are basically, they are there for thickening of my capsule. They are inside, not this one. Watch out. This one is outside. And if you want to see them, you have to open this cavity, then only you can see them. Now, someone is going through a sleeve, and this is the tendon of long head of the biceps. And now we don't want this to be wiggly here, so it is being plastered with this space by these transversely going clips, and this is my transverse humeral ligament. Are we good so far? So this long head is going over. So it is playing a big role in keeping the head of the humerus in its location. Now we can see from inside, let's label it. The capsule has been opened up. So coracohumeral ligament is a separate entity. It's not connected to us. So you can see that coracohumeral ligaments, and out of this coracohumerals, you're looking at superior, middle, and inferior. Are we good so far? Then the same thing, you're looking from different angle. Now, we are looking at, we talk about these conoid and trapezoids. We talk about these ligaments. Now you can see here, my joint, the bony surfaces are covered by hyaline cartilage, the glenoid cavity and the head of the humerus. And there you're looking at the joint cavity. And this is the, can you see this pinkish structure? This is my synovial membrane, which is responsible for the production of synovial fluid. Synovial fluid is just a layer, a thin layer. Its job is to lubricate the surface, so there should not be any friction. Now, guys, this is important. Let's look at the scapula from a lateral view and let's reconstruct it. Now I have put what? This shining grayish structure is my hyaline cartilage. And then these are the structure, we have talked about it. Now, this light gray thing is my glenoid labrum, and you can see this is where the tendon of long head of the biceps is going traversing there. We call it glenoid labrum. And then the fibrous joint capsule. And we talk about this axillary recess. Now, look at it. You're looking at the supraspinatus muscle. You're looking at the infraspinatus muscle. We're looking at the teres minor muscle. And from the front, we are looking at what? Subscapularis muscle. Now what happens? There is a bursa, subacromial and subdeltoid. And then there is a very strong ligament which makes an arch here between the acromion and coracoid. Coracoacromial ligament. So partially bones and partially this ligament, they are making a very strong upward bridge, and that is known as coracoacromial ligament, and they are making a complete arch above it, bones and ligament, and then above to it we have the deltoid. So you can see that the head of the humerus fits here. Superiorly we have so many strong structures. Anteriorly we have this subscapularis. Posteriorly we have these supraspinatus, infraspinatus and teres minor. But we don't have anything inferiorly. So if we have dislocation occurring at the shoulder joint, first the head of the humerus falls out. So first is inferior, then it may go anterior, it may go posterior. But it usually never goes superior. It cannot enter, it may, but it's not. First it goes inferior, then it can go anterior or it can go posterior. So the most common dislocation which occurs at my shoulder joint is anterior inferior. Are we good? So there is no support. So here we can see only the capsule is alone. No one else is there. And this is the direction which is taken by the head of the humerus if it falls out. Are we good? Guys, this is a very important concept and you are expected to be well connected with this. Now, look at the axes. The different movements which are occurring at my shoulder joint. Look at it. Flexion extension in sagittal plane. Abduction adduction in coronal plane. And medial and internal and external rotation or medial and lateral rotation, they are occurring where? In the horizontal plane. These planes are important. And now look at the bursas around my shoulder joint. They have already been labeled. And now look at when it dislocates. See, the head of the humerus, we have talked about it. When it's a dislocated head. First, it goes inferiorly. You remember pectoralis major is attached. When it goes inferiorly, Pectoralis major and subscapularis, they pull him medially, so it goes anterior. Are we good? And look at it. Compare. If you see someone who has a history of a fall on his shoulder tip. Now compare this contour with this contour of the shoulder. Can you see there's a dimpling here? And look at it, this is full. And that is the loss in contour of my shoulder. Are we good? Okay, guys. So what do you see? Can you tell me what's wrong? Is there something wrong with this shoulder joint which you're looking at? Yes or no? Look at it. Remember in the beginning, we talked about that these rings, they should coincide, but this is an anterior inferior dislocation of my shoulder joint. And what about this? Yes, anterior inferior. Perfect. You guys are pro. Now see, when this will be happening, what are the possibilities? Guys, this structure is my axillary nerve. Look at it. It follows, the head falls out. So who's in danger? My axillary nerve is at risk when there is a dislocation occurring at my shoulder joint. One has to be very careful in documenting about any injury which occurs maybe due to this dislocation, or once you're trying to fix it back, you may cause this damage. So one has to be very careful for this axillary nerve. Are we good? Now you can see that superiorly how strong is this arc, and it's worth mentioning, and we call it coracoacromial arch. It is partially made by this coracoacromial ligament and then these bones. Guys, highly recommended. When you'll be visiting your labs, you should see this model and spend time with this learning. Now, guys, we spend good time in learning about shoulder joint. This is a key slide, Zibda. This is a must-know information about a shoulder joint. If you know this much, you are enough. You have done everything. So this is a key slide. If you don't know anything out of this, means you don't know about shoulder joint. Now let's look at the ligaments who anchors my clavicle. So now let's label them. There's a ligament who connects the two clavicles. Clavicle with the sternum, sternoclavicular ligament, costoclavicular ligaments, and then laterally we talk about these four: coracoclavicular ligaments and then acromioclavicular ligaments. Are we good so far? The clavicle moves. You have discussed this concept during your foundation, and Dr. Ayman spent good time. We know about this ligament who extend between the acromion and the coracoid, coracoacromial ligament. But today we'll be talking about this joint. And what is this joint? Acromioclavicular joint. What happens here? Guys, pay attention. We're talking at this joint. We talk about these ligaments, conoid and the trapezoid, acromioclavicular is the normal image. Now, same drawing, somebody falls on his shoulder tip. Now, as a result, there are possibilities, injuries occurring, and that will result in damages. It could be one or it could be all. And if they are damaged, what are the possibilities? We'll have shoulder separation, and you are expected to differentiate between shoulder dislocation and separation of the shoulder. And there is very clearly been mentioned that what is shoulder separation and what happens and what are the differences between two. Guys, now look at it. Because this shoulder is separated, this part of my clavicle is free from the acromion. So it is been popping upwards. So you can see there's a bulge occurring under the skin, and this is my shoulder separation. All these has been damaged. And this red line, which was aligned together, now this end is free. So this hand is being saggy, is shrugged, and it is going downwards. Now, this is a must from acromioclavicular joint. Quickly recap. This is an atypical type of plain synovial joint. Why it is atypical? Because the articulating surfaces are lined not with hyaline, they are lined with fibrocartilage. Now, the last joint for today, sternoclavicular joint. Guys, this sternoclavicular joint is also an atypical synovial type of joint, occurring where the medial end of my clavicle with the sternum, manubrium part of the sternum. This is a saddle type of atypical synovial because the lining articulating surfaces of these bones, they are lined with fibrocartilage, not with hyaline cartilage, and there's a disc in between. So these are the list of the ligaments who are contributing in making this joint. And then this is the detail which is a must know about this sternoclavicular joint. Remember, acromioclavicular joint and sternoclavicular joint, both of them are example of atypical synovial. The sternoclavicular is saddle type and the acromioclavicular is a plain synovial joints. Thank you very much.